Good afternoon, everyone. Hello, everyone, and thank you for joining us for the second Impact Talk of 2024. Our Impact Talks are designated to educate and inform our students, prospective students, and community about the broad reach and impact of social work and nonprofit management by showcasing the expertise of our faculty, lecturers, community partners, and research associates. We began offering these Impact Talks in 2022 to recognize Social Work Month and had approximately 339 registrants across our in-person and online platforms. Last year, over 900 persons registered for our 4 Impact Talks. We are pleased that, like last year, to offer free continuing education credits, CEUs, for those attending these talks. My name is David B. Miller, and I'm the Associate Dean for Academic Affairs at the Mandel School. Today, I have the honor of introducing our speaker and my friend, Dr. Nguyen. Ann currently is working as an associate professor at the Mandel School with a focus on interpersonal practice with individuals and families, psychological assessment and diagnosis, religion and mental health, gerontology, multiculturalism, and diversity in social work practice. Some of her research interests also include African American mental health, social relationships, cognitive decline, and sleep disparities. I'm sure our students know about sleep disparities. Within her research and career, Ann has been the recipient of several awards and honors and has additionally worked as a social work field instructor and psychotherapist. Ann is continuously working to improve her knowledge and bring awareness to the findings in her research. She is extremely knowledgeable and trusted in the field. Ann is frequently appearing in the media, peer-reviewing presentations and publications, presenting on her work, and so much more. Today, Ann will share a little more about some of her research and the knowledge she has gained throughout her career. So please join me in welcoming Ann Nguyen.
Thank you, David. Thank you for the wonderful introduction, and thank you everybody for being here, and thank you for your support. So today I'm going to share with you my research on social disconnection and cognitive decline among older, middle-aged, and older Black Americans. So I'd like to first start off by giving you an overview of the older adult population in the US. So this graph here depicts the number of older adults in the US, starting from 1920 in the far left-hand corner here, all the way to 2020. And this is based on census data. So the main point that I am trying to get at is that the older adult population has been increasing over the years, and it's really been increasing precipitously in the last few decades. So currently there are 55.8 million older adults in the country, in the US, and think about it in another way. That's 1 in 6 people who live in this country. 1 in 6 people who live in this country are older. And just to give you an idea of the older population in Cuyahoga and the surrounding counties, this is a map of all the counties in Ohio. This comes from the US Census website, and it depicts the proportion of older adults in each one of these counties. So the darker the green, the greater proportion of older adults. So looking at Cuyahoga County, 16.3% of our county is comprised of older people. Lake County, that's 18.5. Geauga County, it's almost 20%, so that's almost 1 in 5 Geauga resident is an older person. And Lorain County is about 17% older adults. So this infographic it shows the projection of older adults as well as children living in the U.S. So I want you to actually take a look at the lower portion of this infographic. So on the left-hand side, that's the 2016 data. That's based on actual census data. And then data for 2035, 2060 are projections based on the data that we have from the U.S. Census. The green bar represents older adults, and the red bar represents children. So what I want you to focus on is 2035. What this is saying is that by 2035, older adults will outnumber children. And then by 2060, older adults will outnumber children even more. And this is in contrast to 2016, which children actually outnumber older adults. So what this is saying is that we are growing older as a country. And this has implications for aging-related diseases, such as dementia and Alzheimer's. So dementia is the 7th leading cause of death in the world. And I want to share this with you because I find this fact interesting. Typically, when we think of dementia, we don't think of dementia being a killer. When we think of dementia, we think of people who are having memory problems, who may be experiencing lapses in memory, but we don't think of dementia as being fatal, but it clearly is. So this really demonstrates how severe of a public health problem dementia is. So one of the risk factors for dementia is age, of course, and it's not just being an older person puts you at risk, but among older people, the older you are, the greater your risk for Alzheimer's and dementia is. So for example, these green bars that you'll see is the prevalence rate for Alzheimer's among white older adults. So among white older adults who are 65 to 74, 3% of this population has Alzheimer's. Now this jumps to 11% among white adults who are 75 to 84. And then when we look at 85 and older, this increases further to 30%. So almost 1/3 of older white adults who are 85 and older have Alzheimer's. Now, looking at the black population, older black population, which is represented by these blue bars, we see that for black adults who are 65 to 74, 9% of this population has Alzheimer's. And notice that 9% is 3 times that of 3%. We see a racial disparity there already. And the percentage jumps to 20% among older black adults who are 75 to 84. And then it further increases to 59%. So that's over half of the black population that is 85 or older has Alzheimer's. So the main point I wanted to get across to you from this graph is that the risk for Alzheimer's disease and related dementias increases with age in later life. And the risk for Alzheimer's disease and related dementias is greater among older black adults than older white adults. Like many other health conditions, there are racial disparities in Alzheimer's disease and related dementia, which I'll abbreviate as ADRD from here on out, as you saw on the previous slide. So compared to white Americans, black Americans are Black Americans are 2 times more likely to have ADRD, which you saw on the previous slide, but that's not the only disparity. Black Americans are also less likely to have a diagnosis. So the implication of this is that without a diagnosis, it's very difficult to receive treatment and services for Alzheimer's. Black Americans are also diagnosed in later stages of ADRD. And the implication is that in later stages of ADRD, caregiving becomes more intensive as well as expensive. And the other important thing to remember is that many of these Alzheimer's medication that we have seen that's out there, and several of the ones that we have seen that's been quite controversial over the past few years, these medications really are meant for people who are in the earlier stages of Alzheimer's. So if you're diagnosed in later stages of Alzheimer's, you don't qualify for these Alzheimer's treatments. Furthermore, Black families provide more intensive caregiving than white families, and the healthcare cost is higher among Black Americans with Alzheimer's than white Americans with Alzheimer's. The cost of providing care to family members is greater for Black families, and the families of Black women with dementia bear 60% of the national dementia care costs. Now, these disparities that we see in ADRD, these racial disparities, are in large part shaped by racism. For example, racism shapes social determinants of Alzheimer's. One of the biggest protective factors when it comes to ADRD is education. And access to education and the quality of education is very much shaped by structural racism in this country. Environmental exposures, healthcare, access to healthcare, the quality of healthcare, provider biases, and all of these factors contribute to accelerated aging and inflammation, which also contributes to ADRD. And finally, research can also contribute to this disparity. So despite the stark racial disparity that I've shown you, most of the research in this area has focused on either the general older adult population, which is predominantly white, or specifically on older white people. So we know very little about what ADRD or cognitive decline looks like among older Black adults. And we also don't really know a whole lot about risk factors and protective factors for ADRD in the Black population, especially those that may be unique to this population. And we really need more research that's focused specifically on Black older adults so that we can understand what is driving these disparities in ADRD so that we can work towards cognitive health equity. So social disconnection is another risk factor for, besides age, is another risk factor for ADRD and cognitive decline. So social disconnection is a broader term for terms like social isolation and loneliness, which you probably have heard. You're less likely to have heard the term social disconnection. So you can think of social disconnection as more of an umbrella term that encompasses social isolation and loneliness. So social isolation really refers to an objective state. So a state when somebody is objectively isolated from people. So people who objectively lack contact with others, lack interactions and relationships with others. Whereas loneliness is more of a subjective term. So it is the perception that you don't have the amount of contact that you desire, or the amount of interactions that you desire, or the quality of relationship that you want. So even though social isolation and loneliness are related, they are two distinct terms. So somebody can be socially isolated but not lonely. So think of people who enjoy solitude, right? So they're objectively isolated, but they enjoy being isolated. They like the solitude. On the other hand, somebody can be lonely but not isolated. So the term being lonely in a crowd, right, I think exemplifies that. So to understand why social disconnection is so harmful to cognitive health, as well as just health more broadly, I think it's important to understand why relationships are important to us. So our relationships provide us with social support, social interactions, and social engagement. And all three of these factors have both direct and indirect implications for health and well-being. So that's why being socially disconnected is equivalent to smoking 15 cigarettes a day. And this is in terms of the health effects of social isolation. And the reason why social disconnection is so harmful to our health is because we as humans are really meant to be social creatures. So you've heard about species that are social, right? There are certain animals that are meant to be social. We're one of those species. So we need our relationships, we need interactions, we need social ties in order to not just survive, but to thrive. It's a form of nourishment for us. So when we lack these relationships, whether it's perceived or real lack of relationships, it represents a state of threat for us. So we are under threat when we're socially disconnected. And so if we remain socially disconnected for an extended amount of time, that amounts to being in a persistent state of threat. And being in a persistent state of threat is basically a chronic stressor, right? And we know that chronic stress leads to a multitude of health problems, including cognitive problems. The other big thing to keep in mind when we think about loneliness in older adults is that older adults who are lonely are more susceptible to romance scams. So older adults who are lonely really want to make those connections, right? So when a scammer reaches out and try to connect with an older person who's lonely, that person may be more receptive to that contact and they may be more compliant. So these are a few articles in the last few years that have featured romance scams among older adults. And these articles discuss the role of loneliness in making older adults more susceptible to romance scams. So in recent years, a number of organizations have really recognized the importance of understanding and addressing social disconnection and have really stepped up in solving this social issue. And one of them is the U.S. Surgeon General's office. So just last year, this report was issued back in May of 2023 called Our Epidemic of Loneliness and Social Isolation. This was issued by our Surgeon General's office. And what it did was it labeled social isolation and loneliness a public health epidemic. And this is significant because it recognizes that these social problems have significant health implications. And it also identified mental and physical health outcomes of social isolation and loneliness. So I would like to note that social disconnection is linked or shaped by racism. So what I mean is that structural racism shapes environmental factors that can influence social disconnection. For example, factors like residential racial segregation, neighborhoods with disadvantaged built environments, neighborhoods with limited social and economic resources, and gentrification. So all of these characteristics can be risk factors for social disconnection. And African Americans or Black Americans are more likely to live in neighborhoods with these characteristics than white Americans. Thus, Black Americans are exposed to a greater number of risk factors for social disconnection due to racism. In my own research, I've also found that discrimination can lead to loneliness. So it can lead people to perceive that they lack meaningful connections. So given our very limited understanding around ADHD and cognitive decline among older Black adults, the aims of my study are to first identify cognitive status trajectories among middle-aged and older Black adults. So what I mean by this is I want to see if there are changes in people's cognitive status over time or does cognitive status stay the same over time? The second aim of my research is to determine whether social disconnection in the neighborhood environment are related to cognitive status trajectories. So once I identify these cognitive status trajectories, can social disconnection in the neighborhood environment predict which trajectory a person ends up in? So for this study, I used data from the Health and Retirement Study, which is a national panel study of middle-aged and older adults. Data was collected every 2 years, starting in 1992. Data for the current study come from the 2006 to 2020 waves of the HRS with 4 measurement time points, or 12 years study period. The analytic sample included 1,791 Black participants aged 51 and older. These are community dwelling participants, so nobody who's institutionalized was included in this study. So in terms of social disconnection, I was interested in disaggregating social isolation, meaning that I wonder if being social isolated from one group is different from another group. So I looked at social isolation from extended family, from children, and from friends, because I wonder if being socially isolated from your family is different from being socially isolated from your friends. So social isolation indexes were calculated using social support from these 3 groups, frequency of contact with these groups, and the number of close extended family, children, and friends. In terms of loneliness, I used the UCLA loneliness scale. An example of an item from this scale is how much of the time do you feel you lack companionship? In terms of the neighborhood environment, I looked at neighborhood physical disadvantage using the neighborhood physical disadvantage scale. An example of an item from this scale is people were asked to whether they agree or disagree with the statement that vandalism and graffiti are a big problem in this area. I also looked at neighborhood social cohesion. So neighborhood social cohesion really speaks to solidarity among neighbors, solidarity among people within a neighborhood. So an example of an item from this scale is, I feel that I don't belong in this area. So that would be discohesion. In terms of cognitive status, was a summary score of immediate and delayed word recall, backwards counting from 20, serial 7s, and the possible score for cognitive status range from 0 to 27. 27, the higher the score, the better your cognitive status is. And this was derived from the modified telephone interview for cognitive status. In my multivariable analysis, I controlled for sex, age, education, marital status, and living arrangement, so whether somebody lived alone or lived with others. So this table presents the characteristics of the study sample. So I'm not going to share everything with you for the sake of time. I just wanted to note the gender distribution. 61% of the sample were women. That's typically what we would see among older adults, more women than men. The mean age was 67 years of age. So in my analysis, I identified 4 distinct cognitive status trajectories. The first one here, which I call the very low and declining trajectory, comprised 15% of the sample. And so these people start out at baseline, which is time 1. They start out at baseline with quite low cognitive status scores, and we see a drop in the score over time. This blue bar represents the low and declining trajectory. They comprise of about 1/3 of the sample. So they also start out with relatively low cognitive status scores, but a little higher than the previous group. And we also see a decline over the entire study period. This gold line here represents the moderate and stable group. So they represent a little over 1/3 of the sample. They start out at baseline time 1 with moderate cognitive status scores, and their cognitive status score basically remains unchanged over time, so they remain stable. And then this last group here is the high and stable trajectory. They comprise of about 16% of the sample, and they start out with relatively high cognitive status scores at baseline at time 1, and over time we don't really see a change in their cognitive status score. So their cognitive status remained stable over the entire 12 years of the study. So I was also really interested were there certain types of people who were more likely to be in certain trajectories versus others. So thinking about socio-demographics, right? Were there socio-demographic differences when it came to these 4 different cognitive status trajectories? So I found that there were sex, age, and educational differences. So what we see here is that the very low and declining trajectory had the greatest number of males, and the high and stable trajectory had the greatest number of female, or greatest proportion of female participants. Also, in terms of mean age, the oldest participants were in the very low and declining, and the youngest participants were in the high and stable. And in terms of education, we see that the lowest level of formal education, for about 4 years, was among the very low and declining, and the highest 15 years, was among high and stable people. And this makes sense if you recall that I referred to education as one of the biggest protective factors for dementia. I also found differences in terms of loneliness, neighborhood physical disadvantage, and neighborhood social cohesion. So the highest loneliness scores were found among the very low and declining group, and the lowest was found among the high and stable group. In terms of physical disadvantage, people who were in the very low and declining trajectory lived in the most physically disadvantaged neighborhoods, whereas the people in the high and stable trajectory lived in the least physically disadvantaged neighborhoods. And when it comes to social cohesion, neighborhood social cohesion, we see the highest level of social cohesion, interestingly, among the very low and declining group, and the lowest level among the moderate and stable group. So I found no differences related to marital status and living arrangement, so we'll move on from that. So I also looked at using multivariable analysis, controlling for socio-demographic characteristics, socio-demographic differences. I looked at whether social disconnection in the neighborhood environment could predict whether one person would belong to one trajectory versus another. So in this graph, it shows the likelihood of belonging to the very low and declining trajectory versus the high and stable trajectory. So you don't really have to be able to read this graph. I'll tell you what it says. So what we're seeing here is that people who were isolated from their friends were more likely to be in the very low and declining trajectory than the high and stable trajectory. Similarly, people who lived in physically disadvantaged neighborhoods were more likely to be in the very low and declining trajectory than the high and stable trajectory. Now looking at low and declining, instead of very low and declining, this is the low and declining trajectory relative to the high and stable. We see a very similar pattern. So friendship isolation was linked to being in the low and declining trajectory, as well as living in a physically disadvantaged neighborhood. So people who lived in more physically disadvantaged neighborhoods were more likely to be in the low and declining trajectory rather than the high and stable trajectory. And looking at the moderate and stable versus high and stable trajectories, we see that people who were isolated from their friends were more likely to be in the moderate and stable trajectory than the high and stable trajectory. So I also examined how the neighborhood environment might interact with social disconnection to influence cognitive decline. So what I found was an interaction between neighborhood physical disadvantage and loneliness. So this line here represents the relationship between loneliness and being in the low and declining trajectory for people who are in a low physically disadvantaged neighborhood environment. So the green line represents people who live in neighborhoods where the physical environment is better off, is nicer. This line represents people, the purple line represents people who live in neighborhoods with higher physical disadvantage. So what's really interesting is that I want you to focus on the very low levels of loneliness, which is the very low is the far left of the graph, and the very high levels of loneliness, which is the far right of the graph. So looking first at the very low levels of loneliness, at very low levels of loneliness, we see that people who lived in high neighborhood physically disadvantaged environments, so people who lived in worse off neighborhoods, when we're talking about the physical environment, they were more likely to belong to the low and declining trajectory. And this is what we expect, right? We expect that living in physically disadvantaged neighborhoods would be bad for your health all around, so including your cognitive health. However, if we look at the very high loneliness group, so looking at the other end of the graph, we see the relationship flipped, right? So now the people who are most at risk of being in the low and declining trajectory are actually the people who live in better off neighborhoods. It's in neighborhoods with low physical disadvantage. And what I think is really going on here is that when we talk about Black Americans who live in physically disadvantaged neighborhoods, we might be tapping into racial segregation. So it's possible that many of the people who live in highly physically disadvantaged neighborhoods are people who are also living in racially segregated neighborhoods. So overall, racial segregation is negative. There's no argument around that. But in this specific situation, it may be that living in physically disadvantaged neighborhoods or living in racially segregated neighborhoods, Black Americans may feel that they may feel more of a sense of community in those neighborhoods. They might feel a greater sense of belongingness. There might be more social cohesion and solidarity in those neighborhoods versus living in an integrated neighborhood where they're integrating the neighborhood and experiencing a multitude of racialized stressors in an environment where they're integrating that environment. So what I think is happening is that these characteristics may actually mitigate the effects of loneliness. So although these people are lonely, they live in an environment, a social environment that is richer. So that offsets the effects of loneliness. And I want to clarify that I'm not arguing that people should live in racially segregated neighborhoods or people should live in physically disadvantaged neighborhoods so that they can experience better cognitive health, right? We don't want that. I'm arguing that there are these certain characteristics such as solidarity, community, cohesion in these certain types of neighborhoods that is important for cognitive health. And we need to replicate those characteristics. We don't need to replicate racial segregation. So the current findings indicate that heterogeneity in cognitive status and decline that there is heterogeneity in cognitive status and decline among Black adults. So as we saw, some people experienced decline over the study period while others remained stable. They didn't experience any change in their cognitive status. It's important to distinguish between the types of social isolation. As you saw, it's really being isolated from friends that had the most impact when it comes to cognitive decline. We didn't see an effect for isolation from extended families or from children. So again, friendship isolation was consistently linked to worse cognitive status trajectories. And the relationship between social isolation and cognitive decline is bidirectional, I should note. So in this study, it was a longitudinal study. I looked at baseline social isolation, predicting cognitive decline later basically in the future. But it's important to remember that a lot of people who are experiencing memory problems, who are experiencing cognitive problems, will socially withdraw for a number of different reasons. So social isolation can lead to cognitive decline, but also people who are experiencing cognitive decline might also not want to engage with other people. And it's important to remember that the neighborhood-built environment, alone and in conjunction with loneliness, has important implications for cognitive health. So in terms of practice implications, what can we do with this information? Well, the findings show that friends play an important role in the cognitive health of older adults. So when we're thinking of interventions that help older Black adults build and maintain friendships are really important. Also, these studies argue for more comprehensive assessments of people's social ecology. So I think it's clear from these findings that it's not enough to just assess whether somebody is isolated or not isolated, right? We need to know who is in their network, what do these interactions look like, what do these relationships look like, are our clients or patients' social needs being met with the relationships that they have in their network, right? And finally, we really need to consider the neighborhood environment and neighborhood environmental characteristics in our assessments. I don't think that that's a common area of assessment when it comes to biopsychosocial assessments in social work, but as you see, the neighborhood environment has implications for the cognitive health of older Black adults. So I'd like to conclude by acknowledging the National Institute of Aging for their support of my work, as well as the Cleveland Alzheimer's Disease Research Center and the Research Centers Collaborative Network. Thank you very much for your time.